Because of the time and because of the lot of discussion on cases, I have cancelled that case. I am going to discuss straight about the pharmacotherapy in PH, knowing the drugs. I think the most important thing is pulmonary hypertension management is early diagnosis and early treatment. So everybody knows about this slide. The upgraded classification system is very important for treatment. So I would like to ask, anybody can answer this, what sort of a patient we see in actually practice out of this group as a pulmonologist?
Most of them, sir, are either PH secondary to lung disorders or PH secondary to heart disorders. Primary pulmonary arterial hypertension is quite rare. And CTEF also we are seeing, sir, but mostly type 2, type 3,
so
more common.
How many percentage of your patient goes for a pulmonary artery catheterization?
Very few, sir. Less than.
I totally agree. Very few of our patients goes for pulmonary artery catheterization. Usually 2 and 3.
So most of our discussion is basically we try to differentiate the causes of pulmonary hypertension by thorough investigation, which we have discussed in the morning time. And if suppose we are suspecting pulmonary arterial hypertension, PAH, then we certainly go for some patients. But still, how many of you start directly the therapy without referring for a pulmonary artery catheter? I know we must be starting, otherwise Cipla MRs wouldn't have come to us.
So the right heart catheterization.
Let's talk facts.
Yeah. So majority of the patients are started on the medications, whether it is CTD, ILD. This is where we start with the majority of the patients on treatment. Of course, rest all the patients requires only the symptomatic management like diuretics, oxygen therapy and all. But yeah, we do send. Hardly any patients ever go for the right heart catheterization. Of course, non-availability is the biggest issue.
So the discussion should have been in PH is how to increase pulmonary artery catheterization safely and reducing the cost. I think that point should have been discussed, because where Sujit and me had gone, the pulmonary artery catheterization was done in the wards. Okay, and even not ICU is required. So most of our patients over here go to the cardiologist for in the cath lab. So that's the biggest drawback actually. So if we try to improve that, then probably our pH management will improve. And this is as the pathophysiology is concerned, the genetic and environment factors, and understanding these mechanisms are very crucial when we consider for pharmacological therapy like endothelial dysfunction, fibroblasts and smooth muscle dysfunction and inflammatory disimmunity, etc. So this is just to understand that these are all pathophysiological things going on in the pulmonary hypertension. And these are the target therapies, endothelial pathways like endothelial receptor antagonists, we'll come to that, nitric oxide pathway and prostacyclin pathway, and BMP, the current medicine which is available today is sotatercept, in the BMP activation pathway. Suppose we put the patient on the therapy, okay, can pH pharmacotherapy actually harms the patient with pH, especially group 2 and group 3?
Thanks. Actually, pH medications are mainly indicated in group 1, as we all know. Group 2 and group 3 patients, if we start upfront pH therapy without actually grouping them properly, then definitely they are going to harm, because we are in group 2 patients, we are actually opening the gates of the dam in already flooded environment. And in group 3, unless we control the actual underlying lung disease, there is no use of these medications, and of course they will unnecessarily cause more VQ mismatch, and patient will be more symptomatic and it may complicate. So actually not indicated.
Yeah, so Dr. Tala, suppose it's a fact that majority of the pulmonologists start the medicine. So what sort of precautions they should take, suppose they start in a patient with pulmonary hypertension? They are reasonably ruled out cardiac, your diastolic dysfunction, systolic dysfunction, and respiratory causes, and the remaining things which generally we should rule out. So if they start, what sort of precaution, what should be care they should take if they start, and how they will start the pulmonary hypertension treatment? We'll come to the other thing, but just to in the beginning, how we advise.
So I'm assuming this is without a right heart catheterization, upfront therapy. If on echo, if there is severe PH, dual therapy. If there is non-severe PH, single therapy. I would really encourage everyone to do risk prognostication and write it down at each visit so that you know what it is serially. Don't just tell the patient, "Aap low risk ho, high risk ho." Just document it. It will help you understand as well, and the patient will also at least feel better if they see certain metrics get down. So, risk prognostication.
Which score would you advise for this?
Sir, I'm a Reveal.
Reveal.
Yeah,
Reveal.
I trained with Ray Benza, so
it's
that's
important.
the. Yeah.
So we need to just know.
There is Reveal Lite, easy to access online app hai. You just go in quickly, put in the scores. Within 2 minutes, you'll have a Reveal score. So upfront combination therapy. If the blood pressures are borderline, for me being a cardiologist, if blood pressure of more than 90 is good and the patient is talking to me, I'm happy. So I generally start, if I'm doing a PDE5 inhibitor, I start with sildenafil first, gradually up titrate because it gives you more leeway in terms of titrating. And then once I'm happy with the doses of sildenafil, then I would switch over to a tadalafil, once a day dosing, lesser pill burden. Ambrisentan or macitentan, whatever be your choice. I generally start upfront with 10 milligrams once a day.
Many times patients are on diuretics, many times patients are on your ACE inhibitors, and many times they are antihypertensives. In these patients, you must take a lot of precautions.
Absolutely. So blood pressure monitoring, and if they are on concomitant antihypertensives, maybe lower the dose. If not, stop them initially. And if then if the pressures are still high, you can always resume them
So
back
that's
on.
very important. That postural drop is very important to pick up whether the complications can happen because of it. What goals do you keep, Sandeep, when your patients are starting with anti-PH treatment?
As a pulmonologist, sir, my first goal while starting anti-PH is reduced breathlessness. As symptomatically, if patient is better, definitely that will be my first goal. Also, we do 2D echo screening regularly to understand the RV pressures, and in few 6-minute walk test and our goal is to increase the 6-minute walk test so that patient's capacity is better. Other biomarkers like NT-proBNP and all, but the main goal is to improve the symptoms.
And as a PH specialist, what goal you will keep?
Sir, I
Same
think
clinical, or whether you will also try to improve the right ventricular function and keep the mean pulmonary artery pressure how much?
so on right heart, or just we are still talking
Just
about. So I wouldn't keep any. We should. It all depends on where we are starting from. If we are starting from a mean PA pressure of 100, then even if I get down to 60, 70 after 4 weeks, that's a big win. We are headed in the right direction. So it all depends on where we are. But there are studies which are telling us that it's not purely the PA pressures, and we have to look at it as a overall thing. And what sir just recently just now mentioned, all of those parameters, they are part of all the risk prognostication tools. Just take care of, just make sure, the goal overall is to make sure that your patient comes to a low risk group. So this is what so irrespective of where you start from, if they're in the high risk or intermediate high or intermediate low, they should be come down to the low risk, irrespective of what risk stratification you use. If they're not they do not come down to your low risk group, then that means you have to up titrate therapy. And as you are thinking about adding therapy, maybe that is when you should start thinking about a right heart cath, if not already done. Yeah.
Dr. Deshpande, that risk stratification, how you do it?
We do the risk stratification based on the strata 4 category. We have the low risk, intermediate, high, and high risk. There are several parameters like the functional capacity of the patient, WHO functional class 1 and 2 comes in 1. You have got functional class 3 coming in intermediate high, and functional class 4 coming into high risk. We have the 6-minute walk distance. We have parameters like the NT-proBNP. So if NT-proBNP is less than 300, it is a low risk. 300 to 650 is intermediate low risk, 650 to 1100 is intermediate high, and more than 1100 is high risk. 6-minute walk distance also less than 440 is low, 440 to 320 intermediate low, 320 to 165 is intermediate high, and less than 165 is high risk.
So best thing is to put on the app and get a correct.
Yes.
So that
But,
yes, Sujit.
just a question to Tala also. There's a lot of BNP depleted heart failure also, where you don't see the BNPs go up that much. Also, BNP, is it really written in stone in the sense, don't you need a baseline BNP? I think it's a little variable. Do you think it's that?
Right, sir.
sharp?
And that's why it's not a single parameter. It's everything and all of those parameters being monitored in continued surveillance. So it's not one particular value, but how that value is going. If we start from an NT-proBNP of 3000 and get it down to 1000, that's a big win. But if NT-proBNP is 1000 and we don't know where we are in the middle of everything, we won't know if that's a good thing or a bad thing.
Tala, in this algorithm, okay, Seventh World Symposium, why they have not included vasoreactive test?
In this algorithm, so the right heart in the WSPH guidelines, they clearly mention that right heart catheterization and in selective classes, idiopathic, heritable or CTD toxin related PH, you should do a vasoreactivity testing. You should, because that will obviously add another element to your
in
therapy.
this classification, there is no role of a calcium channel blockers.
Correct, not in these. So that's what I said.
Yeah. So this is non-responder.
These are the non-responders to PH therapy.
So in newly diagnosed pulmonary arterial hypertension classified as WHO group 1 functional cell 2-3, is there any role of monotherapy or should we proceed directly with the dual therapy? Yes, anybody?
So we
Actually we start monotherapy.
Yeah,
Okay.
just like how the Dr. Tala mentioned that we normally start with the monotherapy, we uptitrate and we go to the dual therapy. Now, what the guidelines says is, yes, you can start with the dual therapy. The ambition trial was one of them in which the ambrisentan along with the tadalafil can be given, or along with that, any PDE5 along with the ERAs can be given. So definitely, dual therapy is indicated provided you have an definite evidence along with the right investigations in place. Otherwise, as we mentioned, uptitrate gradually from single to double dose, and whenever you are uptitrating, do the right heart catheterization.
Yeah, but they say that in elderly, frail patient, intolerant to combination therapy, we should consider for a.
So if
Also,
I
I
can
think as Tala mentioned, Prahlad, everyone's not coming in that age group, right?
Yeah.
There are older people coming.
Yeah.
There are also comorbidities, and sometimes we are worried about hypotension starting off with 2 drugs. So that's one of the reasons
that
we
is
start.
the message probably. We should just do not blindly follow the therapy.
If I can just put a point, I mean, they say that you have to risk stratify. If it is a high risk patient, then you give a triple therapy upfront. If it's not a high risk, which means it's a low risk or intermediate risk, then you give a upfront dual therapy as per the ambition trial.
Correct.
But if there is patient with the comorbidities, risk for left heart disease or pulmonary mild parenchymal lung disease, then you only give monotherapy. Then you don't risk stratify the patient. Correct, Dr. Thala?
So let's see what combination therapy we use in a no high risk group of patients. Yeah, doctor.
I think usually we start ambrisentan and tadalafil. I used to start, but now after seeing today's symposium, I think ambrisentan, sildenafil, which we should start. But we have started ambrisentan and tadalafil with very good response to the patients in dual therapy. Low risk.
What about the high risk group?
High risk group, I have not dared to start any medication till now in the high risk group patients, but we definitely have upfront triple therapy for high risk group, which are not very much commonly available here in India, and I have not used myself personally.
So high risk group after a right heart catheterization, you in addition to the upfront dual combination therapy, you start adding your third agent. Your third agent, as we already discussed, can be Selexipag, which will be your triple therapy, or if you want to do a Riociguat, then you'll have to discontinue your PD5. However, if it's high risk, the main thing is to add a triple therapy. In an Indian context where parenteral prostacyclins are tough to get or inaffordable, what you can offer to the patient is inhaled prostacyclins. In our institute, what I follow protocol is, if on dual therapy with addition of Selexipag, if they still remain in the high risk group, I start them on inhaled treprostinil. And
But-
in
Sorry.
so, and if they still don't do well, so once I start inhaled prostacyclins, then I would slowly try to get them off the Selexipag. This is a discussion I was having with another PH specialist yesterday, that combining oral Selexipag with inhaled treprostinil, there is actually no papers on it. The teaching has always been to start inhaled treprostinil and completely stopping the Selexipag. However, what we have seen, and even he sort of admitted to it, is that patients, as you go to higher doses of Selexipag, more than say 800 BD, sometimes you go to 1600 micrograms BD, patients do have a lot of side effects. Bone pain, jaw pain, gastric discomfort is quite significant. With addition of inhaled treprostinil, you can lower down the dose requirement for Selexipag, bring it down to maybe 400 BD, 200 BD. That way the side effects are better and the patients start feeling better. And then there are maybe 5 or 6 patients where I have actually not had the courage to take the Selexipag off because they are doing so well. I've just reduced the dose and kept them on quadruple therapy. I think there's about 6 or 7 patients of mine on quadruple therapy, including inhaled treprostinil. But if they are progressing on inhaled treprostinil, definitely that is when you start thinking about prostacyclins, and in now, hopefully from exactly a month from now, sotatercept. Yeah.
Inhaled treprostinil, you get it through a compassionate basis program, or?
No, sir. So there are importers that are there, and there is a large patient help group as well. If the importers are not able to supply it, I refer my patients to that patient help group, and they're always, the patients help figure out a way to help them out. They'll probably give you a 1-week supply by the time the importer can, get it.
And how much is the cost per month?
About 28,000 rupees per month.
Inhaled, that's Tyvaso.
No, sir. This is Iloprost.
Oh, this is Iloprost. Okay.
Yes.
So just for everybody to get clarification, in this group, how Selexipag is different from the inhaled prostacyclin? Both, one is analogs and other is antagonist.
Yeah.
So what exactly, why this is, what difference is it actually there in between these two?
So Selexipag is it's an oral prostacyclin receptor analog. In terms of effect, it has not only effect on the pulmonary vasculature, it has effect everywhere else. That is why you see this whole prostacyclin sort of effect: bone pain, jaw pain, nausea, gastric side effects. The inhaled agents do not come in with such high prostacyclin. In fact, I've never seen such high headache, nausea with the inhaled agent. So that's a major advantage: selective delivery in the pulmonary vasculature and without much systemic side effects.
So when you increase this dose, how gradually increase?
For
Selexipag.
so
You start with 200
yeah, so I start with 200 BD. Every 2 weeks, I'll go up by 200 micrograms BD, and if they're tolerating well, and if there's improvement, I generally park it at 800 BD. If they are still not feeling as well with 800 BD, and if they can tolerate it, 1600 BD is the highest I go up to. Yeah.
So then after 3 months, we follow up these patients, and goal is again to achieve the low risk status. If low risk status is achieved, then continue the current line of therapy. If intermediate low or intermediate high or high, then escalate. Okay. So with this, what is our line of therapy as well as, I think as a pulmonologist, we go up to triple drug, right? Sometimes when we have confirmed diagnosis of pulmonary hypertension, it comes from the PH specialist, they follow up with us, and then we do that. But what about the adding a fourth drug, or when you have to, what is the maximum therapy means actually?
So maximum therapy in the contemporary world would be PD5, ERA, Selexipag, and parenteral prostacyclin, a remodeling infusion.
So at what stage we generally tell them that kid boss now is finished, we have to think about transplant. So at what level you say here?
The earlier it's better.
Earlier.
From an Indian perspective, assuming that your patients do not have a never-ending financial reserve, all of these drugs can come at a very high cost. So tatacercept is going to be at least 3 to 3.5 lakh rupees per month. Even inhaled iloprost, what I'm mentioning, 28,000 rupees per month is not a small amount to be taken indefinitely. Once I start adding inhaled agents or parenteral agents, in the same breath, I will have the conversation about transplant, lung transplant. I don't want them to get a lung transplant right away. I want them to be familiar with a lung transplant program so that the lung transplant program also knows them. I don't want to refer it to them when their RV is also extremely dysfunctional, because we know very clearly that the outcomes of a heart plus lung transplant is far inferior from a lung transplant alone. So we want to make sure that we, refer at the right time. If your patient for some reason has an unending financial reserve, maybe they are, the Ambanis, then probably you can leave them on sotatercept and prostacyclins. In US, where these were all sort of, the PH therapy was funded by the insurance companies. We had patients live for 15, 20 years on subcute prostacyclin and IV prostacyclin pumps, and were doing absolutely fine. Younger patients, there were a certain few patients where with the IV prostacyclin on board, we were able to get them off the third agent. So instead of quadruple, just PD5 ERA plus Remodulin infusion.
Sujit, you are
Long pressor.
we can talk. We can.
Thanks, Roger. So just to add to what Tala said, I think it's important to refer for lung transplant counseling, not necessarily evaluation. A lot of people think that referral to a transplant center means an evaluation. And I think as pulmonologists now we have realized it, many of us have realized that conversation has to begin. I cannot tell you how important that is, because the later, as Tala mentioned, you send the patient, the worse the outcome. And you don't want it too early either. And there are always new drugs coming on. I mean, you would probably, Tala would probably have a patient who would be on triple drug therapy with iloprost, and he's talking about transplant. Now sotatercept has come. And so you have another choice to have. And as someone says, no, there's always something new. Yes, but there's also a limited lifespan for that patient. So especially when these patients are young, I think that conversation should start. And it can happen once in a year also. If the patient is doing well, that's fine. But let that conversation be ongoing.
It's very important to have conversation. But Sujit, in your practice, you are seeing ILD with pulmonary hypertension. Some of the patient must be primary pulmonary hypertension must be coming to you. So what is the percentage of patients they go for transplant up till now?
In pulmonary hypertension, almost nobody that I am aware of. The transplant indication in India right now, highest is interstitial lung fibrosis. That's the highest. You talk to any lung transplant surgeon. And so our conversations, at least I see a fair amount of ILD, is a lot about just understanding what transplant's all about. The moment they're ambulatory hypoxemia, the moment I know that this patient's quality of life is unacceptable, once they're on regular oxygen, I think it's already a little late to talk about transplant. So ambulatory hypoxemia, I would start PH, pulmonary hypertension associated with ILD. And anyone who's talking about a transplant, can I have a transplant? Let him start that conversation, because he's at least amenable to listen. And then you can tell him that, it's too early or...
So even FVC below 80% is an indication. I mean, we should start talking about transplant.
Yeah, but it's important how you start that conversation. If you say your FVC is below 80, you need to go and meet a transplant pulmonologist.
I think, yeah,
It's
Yeah.
also
it's
easy.
overall.
Patient
Yeah.
will change the consultant.
Yeah.
It's like people said about advanced directives, and we learned that, should you have our patients have advanced directives? I don't want a ventilator, I don't want CPR. And the United States is realizing those advanced directives are often not followed now. But it's not that they're often not followed, they just continue those conversations. So you've had a chat with the patient about invasive ventilation, dialysis in the future, and they said, no, we don't want it. But then they get a pneumonia, come into the ICU and get intubated and come out. So all this can happen. All I'm trying to say is have that conversation. Just keep having those conversations.
Generally, when the patient comes on triple drug therapy or dual therapy, of course, patient is clinically better and he is doing very well for 6-8 months. Generally, as you put an app and find out the risk stratification. But most of you follow that, or you just go by the functional classification, only one in practice, and where you de-escalate.
Sir, I have not tried to de-escalate the patient till now, but definitely patient going from high risk to low risk is the time to reduce the dose of at least PDF inhibitors. I think that we can titrate or shift to medication which is definitely less this thing.
Yeah.
I think.
So I think in PH world we are evolving. We know that if there is improvement in PH therapy, we thank our lucky stars and we keep it that way. We do not stop therapy. We see this so often. Dual therapy improvement either made it into single therapy or stop, and patient comes 3 years later with full-blown RV failure. This is something that should not be done. If there is improvement, we keep it at the same dose and we make sure that we continue to follow them up and not just say, "Aap ghar jao, ek saal baad milenge." Nahi.
So I think this is very practical. Never de-escalate. Just like we have monotherapy role also, de-escalation we should not do. There are trials on de-escalation versus no de-escalation.
I am not aware, sir.
Okay.
We should, though.
I think it's like an antifibrotic in progressive fibrotic disease. Do we stop or reduce? If the patient remains stable for many years, some patients are talking, but then we reclassify the patient. This may not be IPF, and that's why we are stopping the treatment. The same way, probably the patients we are thinking of de-escalating, is that really IPH or was it something else? I don't know if you all ever have that rethink,
So it's interesting you bring that up, sir. There's patients who have been on, not here, but in US, for 10 years on prostacyclin therapy. We started when they're in their 40s. For example, with Sjogren's. We've started them on triple therapy, including a parenteral prostacyclin, and then 10-12 years later, now they realize, they're getting hypoxic and they're getting short of breath. So what's happening over the years is there is unmasking of diastolic dysfunction with aging of the cardiovascular system. So that is one possibility, and that has happened. We've seen that in a couple of cases.
So we have discussed this about vasoreactive testing. Whenever we do a pulmonary artery catheter, we must ask for, and pointed out that we should tell our cardiologist if he's not knowing what is to be used. And this exactly happens. They call us back, what do you mean, what we should do? It's like that. But it's very important to know that these are the drugs, what drugs generally we should use, what dosages are used is very important. It's not a small dose, but a significant amount of doses given. Nifedipine 120 to 240 milligram, diltiazem 240 to 720. Verapamil is not used, remember, amongst all calcium channel blockers. Amlodipine also high dose. So do these tolerate so much dose?
So verapamil and even diltiazem, I would say, is a contraindication. Diltiazem is a potent negative inotropic agent. It has been known to kill many patients of PH. So verapamil and diltiazem, I would strongly discourage. Amlodipine, nifedipine, these are safely used. Patients do tolerate it, sir, but not at such high doses as at least our Indian patients don't tolerate such high doses.
Just take a minute about vasoreactive testing. We discussed throughout the day about the cases of systemic sclerosis who had Raynaud's, And if these patients are already on calcium channel blocker because of Raynaud's, and then these patients go on to develop PH and we want to test vasoreactive testing, what is the protocol? So how many days you are going to, before the test you are going to stop it, or you continue it? And is there any difference in the criteria to say that it's positive?
So if patients are already on, for Raynaud's, if they are on calcium channel blockers for cutaneous ulcers, generally what I've seen in the community is they're on very small, really doses. So it doesn't really affect too much. But if they are on high doses, and even if you're remotely suspicious that may affect your vasoreactivity testing, stop for a week. It won't really do much for, for digital ulcers or cutaneous ulcers.
Endothelial receptor antagonist, another group, and we discussed what are the side effects, toxicity. Now, what is generally the choice among these, bosentan, ambrisentan, and macitentan, and what could be the best choice? What our panelists, what they are generally using?
Sir, we have been traditionally using bosentan. Of course, the macitentan has come off recently. The only problem with the bosentan, which we all know, is the elevated liver enzymes. This is a very much a problem, and we normally try to evaluate every monthly. Macitentan we have started off recently of 10 milligrams, but I have done only on few cases, not on many cases. Ambrisentan we have been using with the combinations, but according to the recent trial, it is shown to have a negative effect. So of late, we have stopped using ambrisentan as a drug.
Your choice, Dr. Tala?
I have stopped using bosentan. I can't remember the last time I've used bosentan. It's either ambrisentan or macitentan. Ambrisentan, I've seen a few patients develop this annoying pedal edema. In those cases, if that happens, then I'll switch them over to macitentan.
Phosphodiesterase 5 inhibitor we have discussed. I don't want to discuss much more on that. And this also we have discussed regarding CTPH therapy. The message also very clear. If you have to be careful with the sildenafil and that group of when you are using this medicine. Now the current any drug which gives mortality benefit.
I think
I think
IV ibuprofen.
That's the only drug which is randomized controlled trial shows that it's giving a benefit, and that treprostinil to some extent it gives. So what about the latest new drug which is there, the fourth group, right? Yeah. Sotatercept. You have experience of using? We don't have that.
No, sir. It's one of my PH colleagues. He's used it in about 3-4 patients. Few of my patients who have now moved out from US to UK, they have started using it, and they are wowed, and they are extremely happy with their results. Very early positive effects. And now the most recent Soteria long-term extension trial also shows that persistent benefits right up to 2 years. So,
at what stage you will add it? As a third drug or the fourth drug?
So third drug too. So that is what the Stellar trial showed, that even on combination dual, you can add this as a third drug. Yeah.
Yes, sir.
So yes, it's a completely different pathway, right? I mean, all of this while we were talking about pulmonary vasodilatation. Now, this is something that is talking about acting on the endothelial cells. So, the proliferation. So eventually, yes, it will help with the pulmonary vascular remodeling. Yes.
Please note the side effects. They are not very common side effects that generally we see. They are unusual, means in the sense related to thrombocytopenia, erythrocyte, hypertension, platelet count.
Yeah, so thrombocytopenia and increased hemoglobin. Bleeding rare. The recommendation is to check a CBC before each dose, at least for the first 4 to 5 doses. And significant bleeding to the point that it requires discontinuation was very rare in the trials. Only happened in patients who were on sort of immunosuppression medications, which by themselves can cause thrombocytopenia and all that. Yeah.
So we discussed group 3, group 2. This is a very nice slide I found, where it favorable no pH therapy and where it favors the pH therapy. In basically group 3 patients. So as the vasculopathy is more, pulmonary hypertension treatment is favorable. If fibrosis is more, then lesser amount of therapy. So it's a good thing to know. We have already discussed this. This is a very nice slide where if you have vasculopathy, then rheosioguat residual in or inappropriate. Do you think that we are overusing rheosioguat?
Honestly, yes, sir.
Yeah, pulmonary hypertension, CTPH is very common in practice.
No, because I think in lieu of surgical therapy, patients are put on riociguat and said that's the cure. So that's why I think it's over utilizing riociguat.
I mean, in my practice, for 5 patients, at least patients who denied surgery or probably we didn't have a surgeon that time, I mean, putting on a RIOC, the systolic pulmonary artery pressures really dropped from around 90 to 60. So I think it does help improve the symptoms also. Yeah, yeah.
As compared to a PT surgery, where you can have...
No, of course, that would be a drastic change. In fact, the cardiologist in this CTEPH patient prefers a dual therapy with macitentan and sildenafil. Is that the norm?
So I don't generally use it, but there are 2-3 patients of mine who have residual pH. Actually, just one patient now has residual pH and is on riociguat with a ERA post PT surgery.
So,
Otherwise, most of them have normalized
so
PA pressure.
you go up to 2 milligram 3 times a day, maximum dose?
2.5 TDS.
2.5 3 times a day.
Yes.
So we already discussed the anticoagulants role. A certain group of patients, there is some role of anticoagulants, especially when you are managing pulmonary hypertension. And so this is my last slide. pH management is a risk-driven, combination-based, and escalation-focused with a new emphasis on disease modification and not just vasodilation. Okay. Thank you very much.
I would just like to add one more quote to it. pH is not a deficiency of sildenafil. So
Just like Zosine is
exactly,
are not,
fever is not a deficiency of piptas.
Yeah.
Same way.
and Indians are not deficient in piptas.
So that was really a wonderful discussion, very engaging, discussing the facts, what we are doing in the real world practice compared to
Thank you,
after
Undu.
the right heart cath. Thank you so much, sir. Dr. Talha, just for the sake of the audience, I mean, what is the cutoff to start these vasodilators, mean pulmonary artery pressure and PVR, non-responders of vasoreactivity testing? 25 is the cutoff, actually, not 20.
None of the trials have looked at mean pH 20.
PVR?
So PVR more than
3.
3 is for the trial. So the 2 to 3 and the mean pH between 20 to 25, they are labeled as early pH, and we don't really know what the impact of therapy will be.
Thank you, panelists, for participating.